the type of surgery, the extent of surgery, and the morbidity and mortality. First of all, we have seen before, we need to define what is a patient or who is a patient with a reduced or with impaired pulmonary function or cardiopulmonary function, so high-risk patients. We already have seen the algorithm from the American Heart Association and the American College of Cardiology, and this is the European algorithm, which is inspired by that algorithm, by the American Heart Association, American College of Cardiology. Probably is a simple, much more simple version adapted to thoracic surgery. But the focus was to emphasize the preliminary cardiac evaluation, even before the pulmonary function evaluation. And the emphasis is put to the use of a risk score, and the revised cardiac risk index was the score suggested by the task force. This is an index published in the 1999 in Circulation, and includes, as you see, 5 factors. But this index was developed from a population from a generic surgical population, so including only 10% of thoracic surgical patients. But you see that what the task force recommended was that when a patient had a revised cardiac risk index greater than 2, then it is necessary to refer the patient for a cardiac consultation, and the patient has to be managed, evaluated and managed according to the American Heart Association, American College of Cardiology guidelines. What we tried to do was to recalibrate the revised cardiac risk index in a larger population of lung resection patients using the same factors. And actually what we found was out of the 5, only 4 of this factor remained significant, and we weighted those factors in the population. So we obtained a nicely calibrated, what we call thoracic revised cardiac risk index, which you will see later, has now been adopted and suggested by the upcoming 3rd edition of the American College of American ACCP new guidelines for lung cancer management in their cardiac evaluation algorithm. So definitely class C and D, so those patients with the thoracic revised cardiac risk index greater than 2 are patients at higher risk of major cardiac events, which doesn't mean atrial fibrillation. We are talking about cardiac arrest, cardiac failure, cardiac death, so major cardiac events. We have already seen DLCO and PPO DLCO, which was popularized by Ferguson in the mid-90s. There is a clear prediction of PPO DLCO and an inverse relationship between respiratory morbidity and mortality and PPO DLCO. And we have already seen these slides, which I think is very, very important because it demonstrates that PPO DLCO is a valuable risk factor for pulmonary complication and mortality, either in patients with COPD and in those without COPD, which means that we have to measure DLCO in all patients. And VO2 max, we have already seen a nice review of all the studies after a few studies, small series published in the 80s. I think this is one of the most important studies published in the mid-90s by Bolliger and colleagues. So they were able to demonstrate that a VO2 max expressed as percentage of predicted, similar to a FEV1 in the LCO. A VO2 max lower than 40 was associated with a risk of complication after lung resection of 90%. On the other hand, a VO2 max greater than 75% had a minimal risk of complication. And this is our series published in Chest of about 200 major lung resection. You see how well, VO2 stratify the risk of mortality and complication in general. So patient with a VO2 below 12 milliliter per kilo per minute had a risk of mortality of 13%. And we confirmed the safety threshold of 20 milliliter per kilo per minute. But the point is that only 15% of our patients nowadays have a VO2 of 20 or greater. So the majority of patients we operate on or that present to a thoracic surgery or to a chest physician are patients with a VO2 below 15. So, and we have to accept those patients and those thresholds. And if you remember, the algorithm from VTS some years ago, they excluded patients, with a VO2 below 15 milliliter per kilo, which is, I think, unacceptable nowadays, because we would exclude 50% of our patients from operation. So this is the algorithm we have already seen before. Clearly, the patients at high risk are those with the unstable cardiac disease, with the risk score greater than 2, and those with a VO2 below 10. So we can say that those patients we can define it as high-risk patients. And this is a preview. This is still not published yet. It will be published in a few weeks. It is the new algorithm from the CCP, the third edition of the lung cancer CCP guidelines. You see that there is a preliminary cardiac evaluation, so sort of come toward Europe and the concept. So preliminary cardiac evaluation, and then the concept of a FEV1 in the LCO was abandoned. So we just took into consideration the split lung function as a first step. So PPO, FEV1, and PPO DLCO measure routinely in all patients and expressed as percentage of predicted. And we recommend a CPET in all patients with a positive high-risk cardiac evaluation, because CPET is not useful just for measuring the VO2 max, but also there are several studies showing that it is a more sensitive test to detect subclinical coronary artery disease, even more sensitive than stress ACG or myocardial scintigraphy. So CPET in this patient, and we confirm the thresholds of 10 milliliter per kilo or 35% as high risk. So another new thing is that we don't say inoperable or suggesting the type or the extent of the operation, but we just classify the patient in high risk, moderate risk, and low risk. And then we discuss the risk with the patient and discuss alternatives. And you see, we introduced the concept of 60% of PPO FEV1 or PPO DLCO. So a patient with the PPO FEV1 or PPO DLCO greater than 60% are regarded as low-risk patients, needing no further test in their evaluation. So this is a preview you will see published in Chest in a few weeks. And of course, the important caveats is that the actual risk of the patient depends not just on PFTs, cardiac evaluation, or VO2 max, but also on many other things, including the structural aspects of the center and the ability to manage complications and the surgical access. So thoracotomy versus minimal invasive, and we will come back later to this concept. So subglobal resection. What is the risk associated with wedge or segmentectomy? There are some studies showing that after segmentectomy, the FEV1 or FEV1, the pulmonary function is much better preserved compared to lobectomy. So there is a lower loss and a faster recovery compared to lobectomy. And in this other study, clearly the patients submitted to segmentectomy were worse in terms of pulmonary function. It was probably a compromised sublobar resection. But the loss in FEV1, not as much as the LCO, but in FEV1 was minimal compared to lobectomy. So we can say that segmental resection is an operation, that compared to lobectomy preserve much more the preoperative pulmonary function. What is the statistics in the ESDS database? You see that the cardiopulmonary morbidity after wedge or segmentectomy is much lower than after lobectomy, and even lower than after a pneumonectomy, of course. And this is the mortality figures. This is the 2012. We have not finalized yet in 2013, that if you will come to ESDS meeting in Birmingham, you will have your Congress back. But the figures are more or less the same, and you see that after wedge or segmentectomy, the mortality rate is about 1.5%, which is much lower than after lobectomy or bilobectomy, of course. Is a sublobar resection an inadequate operation for lung cancer patients? After the first randomized studies, scaring studies published by the Lung Cancer Study Group in the mid-90s, there have been a series of other studies, non-randomized studies, showing that the survival is more or less equivalent, lobectomy versus sublobar resection for early stage non-small cell lung cancer if the patient is appropriately selected for the operation. But on the other hand, the preservation of the pulmonary function is much better after segmentectomy compared to lobectomy. And for sure, if it is feasible, a sublobar resection or even a wedge resection is better than stereotactic body radiation therapy for early stage non-small cell lung cancer. You see here, although the difference didn't reach statistical significance, the two curves are quite separated 5 years, favoring surgery compared to SBRT in high risk